We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Good afternoon, everyone. My name is Jason Sutherland, and I'm proud to introduce the two speakers today, Hiten Naik and John Staples. Both recently completed a great project they're here to talk about today, entitled Are Hospitalized Patients Becoming More Complex? A quick summary of both Dr. Staples and Dr. Hiten Naik. They are clinician scientists or aspiring and emerging clinician scientists, and we're delighted to have them here. So thank you very much.
So yeah, thanks very much for having us. Spoiler alert, the answer to the question is yes. But I want to take you through our process here and describe a little bit about what's known, both in terms of patient complexity in BC, but also more broadly in Canada and the United States. Before we begin, we want to acknowledge that, with gratitude, that we live and work on the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. In terms of objectives, we'll talk about prior evidence on trends in medical complexity. We'll present the results of our study, and we'll consider some of the implications. In terms of our conflicts of interest, we're both clinicians, and so that colors our perspective. We've both received some competitive research funding, both operationally and in terms of research salaries, but primarily from health authorities, hospitals, and CIHR, and we have no commercial interests. In terms of our conflict of interest mitigation, we had editorial independence in the composition of the talk, and we're going to aim for objectivity. Because we're presenting some data from Population Data BC, the traditional disclaimer applies. All the inferences, opinions, and conclusions that we draw are ours and don't reflect the opinions or policies of the data stewards. All right. So with that fronts matter concluded, let's get to the meat and potatoes here. So what we're talking about today is trying to answer this question: are patients becoming more complex over time? And this is a question that came up in my mind when I was sitting in the emergency department reviewing patients with residents and medical students, listening to a list of 20 comorbidities and 25 medications, hearing about how they'd survived 2 cancers and had a transplant, and thinking, holy moly, like, this is really complex. Was it like this when I was a resident? And when we looked around, we found out that we weren't the only people that had this feeling that patients became more complex. So here's some quotes from a variety of folks. Here you can see over on the far right-hand side, the CEO of the American Medical Association talks about an ever-growing tsunami of chronic disease. Just above that, you can see the UK Secretary of State for Health and Social Care talks about increasingly complex needs of their patients. And in the lower left-hand side, you can see a commenter in the New York Times talking about increasing medical complexity, steadily increasing over time. So this was certainly an impression that we weren't the only ones that held that impression. But when we went to look at data about medical complexity, specifically in hospitalized patients, we really didn't find very much to support or refute that notion. So first, I want to take the devil's advocate position here that complexity is claimed by clinicians and health systems, but the claims are overblown and it's not actually true. Let me take you through some of the arguments for that. So first, we know that a number of cognitive biases might predispose us to thinking that patients used to be simpler than they were. Mostly it's this good old days bias, the idea that we look back on our past with a rosy glow. And this is something that was, the Romans even did, and they called it, let's see if I get this right, Memoria Praetorium Bonorum, which is pretty catchy, and really just means that that the old days were better. So these biases might lead us to think that complexity is increasing and things were simpler in the past, but that might be false. The second reason why this impression of increasing complexity might be overstated is because a number of incentives in the healthcare system might lead clinicians or healthcare leaders to claim that complexity has increased over time. So the first is a set of financial incentives. We know that both clinicians and hospitals in many settings are incentivized to overstate complexity or upcode, find the people who have marginal diabetes and code it in there so that they can claim more payments. The second reason is in settings where clinicians are paid a daily rate, they might be incentivized to overstate complexity to minimize their patient panel. The third is there are lots of financial incentives to increase the amount of imaging and the amount of screening, which might pick up incidental disease over time. We also thought about evolving expectations that might bias this impression of complexity. So patients probably expect more now in terms of explicit statement of their comorbidities and maybe more tests. Physicians maybe have greater expectations about their lifestyle now than they might have before. And so staying until 8 p.m. to look after a complex patient might have been acceptable in 1992, but in 2024, the physician might want to head home to pick up his kids at 4 o'clock. And third, there's an increasing expectation by venture capitalists, particularly in the United States, for protected profits over time. So all these incentives might cause us to overstate the change in complexity. Now, the next thing that might contribute to a false impression of increased complexity is the appearance of increasing multimorbidity arising from early detection of disease, overdiagnosis, medicalization of normal aging, or upcoding. So we talked about upcoding. This figure, I want to talk a little bit about overdiagnosis. So this shows its time series on the x-axis. There's 1975 to 2015, and this shows data about melanoma. So cutaneous melanoma, the incidence has increased fivefold since 1975, but the mortality from the condition really hasn't changed. And the reason the authors surmise here is that it has to do with a greater number of biopsies and upstaging of pathology, essentially overstating the incidence of the condition and identifying the disease when in fact it never would have caused metastases or affected the patient's outcome. So this is representative of other conditions like small renal masses or many other things that are picked up with greater frequency but may not actually affect individuals' outcome. And then there are other topics like low T or low testosterone in middle-aged men, which is arguably normal aging, but has been identified in a number of health systems as a treatable condition. The next reason why the impression of increasing complexity might be false is there have been a number of victories in public health over recent decades. So as an example, this is the number of traffic fatalities per 100 million vehicle miles traveled between 1974 and 2021. And you can see that your risk of being involved or being killed in a traffic crash has fallen by almost 2/3 over that period of time. And that's mostly a victory of public health. And this makes patients, overall victories in public health make patients healthier and less complex to look after in the hospital. Sort of on a similar topic here, this is the sales of cigarettes per adult over time from 1900 up to 2014. And you can see it peaked in the 1960s in Canada and the United States. And since then has also fallen by about 2/3. And as a result, lung cancer death rates have really fallen in tandem with a little bit of delay. And so these public health victories probably have made patients healthier and simpler to look after. So another argument for why complexity isn't increasing is that our overall medical care has probably improved substantially. This is in some ways hard to prove at a large scale, surprisingly hard to prove. But here I've taken data from the US SEER registry, which is a registry of cancer treatment and mortality in the United States. And I've looked at 5 cancers which are less subject to early detection bias, and looked at the 5-year mortality. And you can see over time, outcomes have improved tremendously. So for example, for esophageal cancer, the green line on the top, your likelihood of dying from esophageal, or of surviving 5 years after esophageal cancer, has gone up 4-fold since the mid-1970s. And so improvements in medical care have improved outcomes and probably make it simpler to look after patients. Sort of a combination of improvements in public health and improvements in medical care have led to a very dramatic decline in cardiovascular deaths. So this is, the population incidence of cardiovascular death over time in a number of countries. And you can see that in places like Canada and the United States, there's been a 5-fold reduction in cardiovascular death rates. And that probably makes people easier to look after. So one of the final reasons why I think maybe complexity is less now than it was before is we've got very effective treatments. So this is a series of photos published in the New England Journal of Medicine in Images in Clinical Medicine, and this is all the same patient, and on the left is when the patient first presented to a clinic with metastatic melanoma, and he was treated with targeted therapy. And by panel C, that's 12 weeks later, just 12 weeks, like a miraculous improvement. And this is the kind of progress that's been made in terms of medical care in the last 20 years. And there are many other examples of less invasive surgical procedures, TAVIs, laparoscopic procedures, IR-based procedures, all of which make medical intervention less morbid for patients. So, and the final reason that I want to argue that maybe complexity hasn't increased after all is, frankly, our life expectancy has improved dramatically in recent decades. And so if you accept the premise that death is a function of health, then the average 82-year-old now is as healthy as a 68-year-old was in 1950. And that's very impressive. So maybe age is just a number after all. All right, so here are the arguments that I made for the idea that increases in complexity are overblown. They include cognitive biases, perverse incentives, overdiagnosis, public health successes, more effective medical care, and increases in longevity. Okay. So now I want to wear the other hat and convince you, actually, there's a lot to say that complexity actually has increased dramatically. So we'll go over some of that evidence and then talk about our study in particular. So, we just looked at this slide. This is life expectancy. The flip side of the coin is that we are seeing patients who are older now in hospital and in clinics than they were before. And with age comes disease, particularly degenerative disease and frailty. And that makes patients more complex to look after. My second point here is that the prevalence of non-communicable diseases has increased dramatically in recent years. So this is some data from the United States. It's a chloropleth map with darker colors representing a higher prevalence of diagnosed diabetes. And you can see on the left there in 2004, or looking on the right at 2021 compared to 2004 on the left, you can see the prevalence of diabetes has more than doubled, in some cases tripled or quadrupled by county. And this is not just true of diabetes, it's true of many non-communicable diseases. So this is data from the Global Burden of Diseases study, headquartered in Seattle at the IHME. And this looks at, on the y-axis, disability adjusted life years, which is a sort of cumulative measure of the burden of disease. And you can see here between 1990 and 2019, the cumulative burden of disease in the United States from non-communicable diseases increased by maybe about 30%. And this suggests that patients are coming in with more multimorbidity than ever before. This is also true of end-stage disease or organ failure. So this is data from the United States on hemodialysis and other forms of renal replacement therapy. So you can see that between 2000 and 2020, the number of people on hemodialysis doubled in the United States. And I can tell you the population did not double in that period of time. So more of those people are coming into hospital, and indeed, in the middle line there in blue are patients who received a renal transplant, and that doubled as well. And so these patients are more complicated to look after, and they're ending up more often in hospital. In addition to more diseases, people are on more medications. So this is survey data from the United States. And you can see there in the top line, it records the number of patients over 65 years who are on 5 or more prescription medications. And you can see that that number increased from around 15% to about 40% on the most recent iteration of the data, suggesting that more patients are coming in on a large number of medications. When I look at my own experience since I first showed up at St. Paul's on my first day of residency 20 years ago, a whole host of new medications have been released, including some very impressive and highly effective medications. And when I look at this list, it intimidates me. The sheer number of things that you have to learn after you're supposedly finished your training is shocking. And the evidence bears this out. So this is data I downloaded from the FDA website about the number of new molecular entities or new drugs approved by year in the United States since 1940. And you can see that particularly since the 1980s, the number of new drugs has increased and maybe even accelerated per year. So those are all new drugs and new complications of those drugs that clinicians need to deal with. One way of dealing with these complications and new drugs is to subspecialize. So this is data from the American Board of Medical Specialties, the organization that approves medical specialties in the United States. And you can see that there's been a relentless growth in the number of specialists since the 1920s, and maybe even accelerating growth. And so now in the United States, there are 189 approved certified medical subspecialties. And as a result, there's been increasing fragmentation of care. So this is a bit of a busy slide. I want you to just focus on the right-hand side and on the top blue line. On the x-axis is the year from 2009 to 2019. And on the y-axis, it shows the percentage of visits that ended in a consultation with a specialist in the emergency department. So this is for shortness of breath, a very bread and butter topic in the emergency department. And since 2009, the proportion of patients referred for specialty consultation went from 10% to 30%, again, using survey data from the United States. So more specialists means more fragmentation of care. More drugs, more specialists, all that means more knowledge. And so this is data from PubMed, just looking at the number of clinical trials published per year. And you can see that even if you compare 2020 to 2000, the number of clinical trials published per year has approximately doubled. And that's all new medical information that clinicians need to keep track of. All right, so wearing my complexity has increased hat, I argued that complexity might have increased dramatically because of population aging, because of the epidemic of non-communicable disease and multimorbidity, because of more people with advanced cancer or organ failure, because of the fire hose of new drugs and the increase in polypharmacy, because of specialization and fragmentation of care, and because of a rapid expansion of knowledge over that period of time. So after thinking about this, we still didn't know the answer because of course, we're specifically interested in hospital inpatients, which is where I work. So we were really stuck with this question, are claims of increasing complexity overblown, or has complexity actually increased dramatically over the time that I've been in practice? So I'll hand things over to Hiten now to talk about our study.
So focusing on hospital inpatients, the objective of our study was to assess whether there's been an increase in measures of hospital inpatient complexity over a 15-year period. So for like any study, we need to understand the study setting. So this was based all in British Columbia. At the end of the study interval that we looked at, there were about 4.9 million residents. But what's important to note about BC is that it's quite large, and obviously that creates challenges when it comes to complex patients. We have a universal healthcare system with predominantly fee-for-service model that allowed us to capture data from the entire province. That was very complete. And our data comprised of information from 101 acute care hospitals. And as you know, there's a diversity of hospital settings from small, rural, remote hospitals to larger academic coronary medical centers. So we used linked health administrative data from POP Data BC. This data included hospital discharge abstracts, which are derived from the discharge summaries that we all write, physician billing records, Canada Census Tract files, PharmaNet databases, and vital statistics. So our basic study design was that we looked at between April 1, 2002 to 31st of January, 2017, and we looked at all elective, non-elective admissions during this time. And for each admission, we looked at characteristics at the time of admission, and we did a 1-year look back to develop characteristics of those patients. And then we also looked at the length of stay, and then we looked 30 days after their discharge to see whether they've had a readmission or death. So in the literature, there isn't a single measure or agreed upon way of measuring patient complexity. A lot of it is context dependent. And so our context was hospital inpatients. So we came up with a panel of metrics that we thought reflected complexity of hospital inpatients. And there are 3 main categories. There were patient factors at admission. So these are things like the patient's age, multimorbidity. So we call this the Charlson Comorbidity Index of 5 or greater, polypharmacy, which we defined as 10 or more medications, and whether they were hospitalized in the prior year. And then we looked at metrics that examined hospital course. So this includes whether they were admitted to the ED, whether they arrived via ambulance, whether they were transferred to another hospital, adverse events, whether they had multiple acute medical problems, which we defined as 5 or more medical problems, ICU stay, length of stay, and whether they died in the hospital. And then lastly, we looked at outcomes 30 days after discharge, and this focused on unplanned readmissions and death within 30 days. So when we look at, when we took all of the hospitalizations in BC during this period, you get over 9.6 million hospitalizations. We excluded about 6.3 million because we didn't want to include elective admissions, those with length of stay of 0 days, and those that involved non-adults. And so that left us with about 3.4 million hospitalizations, which are the unit of analysis. So this is the description of our cohort, the main set of results. And so you can see in the second column is 2003, which is the first full year. And the third column is 2016, which is the last full year. And you can see that the median age increased by about 3 years. The sex breakdown didn't change almost at all. And then if you look at comorbidities that increased or in prevalence over the time period, we wanted to point out that psychiatric comorbidities increased, so did kidney disease and diabetes, among others. And then we looked at the most responsible diagnosis. This also comes from the discharge abstracts. And we won't go through everything, but one thing we wanted to point out was that disorders due to psychoactive substance use nearly doubled in prevalence during this time period. I think that's something people at this hospital can appreciate. And so this is our forest plot of our logistic regression analysis, looking at patients' factors at admission, and these factors are dichotomized. So an odds ratio, an unadjusted odds ratio of greater than 1 means that the factor increased over the time period, and less than 1 means that it decreased. And so you can see all of these 4 factors increased over the time period. Age over 75 increased by about 1.3, multiple morbidity about 1.5, polypharmacy almost doubled, and hospitalizations in the prior year also increased. So these are some of the same metrics, but modeled as continuous outcomes on a time series, because we love time series. And so you can see that age gradually increased over the time period. The CCI score, which is the comorbidity index, also gradually increased. And so did the number of medications and the hospital length of days in the prior year. These are the hospital course measures. So there's a whole number of them. And just to give a quick overview, all of them increased except for whether the patient had an ICU stay during their hospitalization and whether they died in the during the hospitalization. The factors that increased the most included admission via the ED, which increased by almost threefold. Admission via ambulance increased by about 1.5-fold. Inter-hospital transfers increased. More than 5 medical problems increased by about 2-fold. Whether they had an adverse event and whether they had a prolonged length of stay also increased during the time interval, but notably they didn't increase to the same extent as some of the other factors. And so one interpretation is that as some of those factors can be seen as performance metrics, you could say that maybe the hospital system was able to keep up with the increase in complexity. So these are 4 of the hospital course measures modeled as continuous variables over a time series. So the number of active medical issues gradually increased. The number of adverse events gradually increased. The number of days in the ICU increased, but more modestly so. And the total length of stay in days also increased, but also to a more gradual extent. These are the 2 outcomes within 30 days of discharge. So both unplanned readmissions post-discharge and death post-discharge increased. Again, the increases in these 2 measures were not as striking as some of the other measures of complexity, and these are commonly used as performance metrics. And so it was sort of satisfying to us that these didn't increase to the same extent. So this is a summary. We looked at a number of different metrics, measures of complexity in the hospital inpatient context. In the first column are the factors that increased, and the second column, the ones that decreased. As you can see, almost all of them increased to a certain extent over the time interval. The only ones that decreased were whether there was an ICU stay during the hospitalization and whether there were deaths in hospital. What was interesting to point out, though, is that the absolute increases in some of the measures when they were modeled as continuous outcomes were more modest, but what was more striking was the relative increases in the dichotomized measures. In other words, the proportion of patients that were over 75 and those that had more comorbidities. And we even used different thresholds for the number of more comorbidities, number of medications. And actually, as we increased the threshold, the extent of the effect was greater. And then, so we interpreted this as, although some of the continuous measures only increased a little bit, because the relative measures increased by so much, this suggests that the proportion of number of complex patients has increased. And we think that this is probably a better representation of what contributes to workload as opposed to the continuous measures. So there are some limitations that we have to point out. So it's important to acknowledge that the measures that we looked at, although we looked at a lot of them, they're not the only factors that are considered complexity factors. What's also important are more of the psychosocial factors that we could not capture in our study. And those included homelessness, frailty, whether there's language barriers and social supports. As we all know, those make patients more complicated as well. And we also didn't really address how accurate the data was and whether the data accuracy changed over the time period, and this could have affected the results. And we also wanted to mention that some of us know there were financial incentives introduced for taking care of complex patients for both internists, subspecialists, and also primary care physicians. And so some of the diagnostic coding may have been impacted by that, but we don't think that explains all of the metrics that we looked at, and not all of the data was based just on physician billing. So complexity has increased. What does this mean? What are the implications of this? So there are implications for clinical training of clinicians. And we have to train clinicians to be able to take care of complex patients. And I think based on how fast knowledge is moving forward, that's not just training people on the medical expert aspects of clinical care, but also some of the non-medical expert CanMed's roles, like learning how to have good leadership skills, learning how to learn new information quickly as it comes up and apply that, learning how to work with teams. There are also a lot of implications for how we deliver care. As there are more patients with complex chronic diseases in the community, there's a trend towards shifting care towards outpatient models such as hospital at home IV antibiotics, and outpatient antibiotics. So that keeps more of the complex patients at home, but that just means that the patients that come into hospital are going to be that much more complex. There's also implications for payment models. So as we showed, the complexity per patient has increased. And so billing or compensating individuals for the number of patients may not be the best approach. And maybe we need to think of other compensation models. Things like fee for service may not be ideal.
Okay, great. So what are the implications for the future? So come with me on a journey to the future. Again, as Hiten said, we really got into time series in this project. Lots of great data out there. This is some from Our World in Data, and it shows the number of patents granted in the United States since 1840. And you can see that overall, there's been an exponential growth in innovation across many, many different topics. And I think that's going to be a theme in the future. Related note is the kind of potential for a coming wave of gene-based diagnostic strategies and gene-based therapies. So this is data on the cost of sequencing a full human genome. And you can see that in 2001, it cost $100 million to sequence one person's genome. And that has fallen logarithmically. And so now it's a few $100s to sequence somebody's human genome or somebody's genome. So I think that's going to have some implications for care in the near future. You know, on the topic of logarithmic change, this depicts Moore's law. So Moore's law is the idea that the number of transistors on a microchip doubles every 2 years. And this has been true since the 1970s. And this is why the phone in your pocket is many, many, many fold more powerful than the computers that launched people to space in the 1960s and 70s. So this has shown no signs of slowing down, and it's going to influence care in the future. The hot topic these days is artificial intelligence, and that the pace of development in AI has obviously accelerated over time as well. This is a bit of a complicated figure, but I want you to focus on the line in blue on the left. And the y-axis shows performance of the AI relative to human performance. And in blue, that depicts handwriting recognition. And you can see it took AIs between 1998 and about 2014 before it achieved human level recognition of handwriting. So about 16 years. Now I want you to look on the far right-hand side of the figure at the yellow line there, which is grade school math. And it took less than a year for AIs to go from being completely unable to do it to having a near human performance. So this sort of acceleration in performance is likely to continue. So what do these things mean for us? This acceleration in complexity and acceleration in technology. Well, we need some ways of adapting our care in future so that we can deliver better care for cheaper and for faster. So I've taken some approaches or some themes relevant to the Industrial Revolution and the more efficient more efficient production of better goods, and tried to apply it to medical care. So here we go. So the first issue is reorganization of labor. We've already seen that over time. There's been subspecialization, and I think that will likely continue. But the other thing I think we'll continue to see is task shifting. So instead of asking physicians to do simpler processes, we'll either ask less trained individuals to work on those, or maybe get AI or other technology to work on them. One idea I want to raise is the idea of deprofessionalization. So if being part of a profession is having command over a specialized body of knowledge, there's the possibility that generative AI renders that body of knowledge less relevant. And so understanding what that future means for the profession, for the medical profession, is one thing that I think we're going to have to struggle with. The second adaptive strategy for complexity might be mechanization. So by that, I mean using some of these technological tools like machine learning and AI to improve our risk stratification, diagnosis, selection of treatment, but even to work on things like population health and administration in a more efficient way. And then also using sort of other techniques and tools. This has been a big theme over decades, is the improvement in medical technology leads to better care that's more efficient, and that's going to continue. I want to raise the POCUS or bedside ultrasound, which has become very routine in care since I graduated from medical school. And I think it's removed a lot of ambiguity and simplified a lot of complexity, but at the same time introduced other complexity, because what do you do with incidental findings? How do you train people to use this new technology? How do you record that information for medical legal purposes? So, there's a double-edged sword when it comes to mechanization and technology as a way of dealing with complexity. Adaptive strategy number 3 is routinization, which really just means checklists in this context. We've used checklists for decades in medicine to reduce variability and to improve performance, particularly of the low performers, and I think that's going to continue. Globalization will continue to be a force in medicine. When I started here at St. Paul's in 2004, I was provided with a really cool new piece of technology. There was a new program called Up to Date, and once per year they would mail you a CD-ROM, and that's how up to date it was. And that was amazing, because otherwise it was consulting literally paper journals. So, obviously now you can essentially access the expertise and opinions of any specialist around the world who's written an article on Up to Date within seconds. Many articles are updated, within hours or days of a new important paper coming out. So that globalization is true of our knowledge, and it's going to increasingly be true of our talent pool, particularly with remote work. The last two here speak to the last few slides that I showed about innovation being very important. There's lots of exciting genetic diagnostic tests, as well as genetic therapies with CRISPR. There's lots of enthusiasm, one might even say foam, about AI in clinical medicine, but it almost seems certain that it's going to change our jobs in some way. And the final point here, data is power. Obviously, the more information that we have about population health and about the health of our patients, the more we can do something to address it. So I hope we were able to deliver on our objectives here. We, just in summary, we tried to use some prior evidence to show that many aspects of medical complexity have increased over the last 2 decades. We summarized our study to show that in BC, hospital inpatients have become significantly more complex by many selected measures over 15 years. And finally, we hope to make the point that clinicians, hospitals, and policymakers need to anticipate and be ready to respond to ongoing increases in medical complexity. We wanted to acknowledge the contributions of our collaborators, including Jason here, and thank the organizations that provided operational funding and research salary funding. And we'd be happy to take questions now.